तो इसमें टेस्टिस पूरा हमने ऊपर प्लास्टर से लिफ्ट करके रखा है और अभी पेन रेप हो रही है। And then make the area sterile. Then we take the ultrasound probe. Then we adjust the height of the ultrasound console so that we can access it. Then we take a condom and we put some ultrasound gel inside it. And then the condom is put on the probe. And care should be taken not to overstretch it. And we would want as less air as possible inside. And then this is the transperineal guide, and this will be installed on the probe. And then there is a lock. Again, some air which has to be removed and has to be removed. Make sure that there are no air bubbles on the transducer, and then we insert the probe. Jelly.
Does everyone know Isabella?
Yes.
So, what is the name of the procedure plan?
Transperineal biopsy.
Is the correct height verified by the operating surgeon?
Yes.
Is the correct height frame or draft?
Yes.
Antibiotic prophylaxis given in 60 minutes.
Yes.
Is it your
Magnex foot. 1.5 gram.
dose 1.5 grams? Time? Is it pre-op? What are the critical or non-routine steps about this surgery?
All routine steps, no critical events anticipated.
Is there anything critical or non-routine about this surgery?
No.
Expected duration of procedure?
15 to 20 minutes.
What is the anticipated blood loss?
Minimal.
Is there anything critical or non-routines about the anesthesia administration? Is sterility is
Yes, confirmed.
there any equipment issues or concern?
No.
Is essential imaging display?
Yes.
Yes, sir. Available.
Is DVT pump? in place?
Not applicable.
Thank you.
So now we put the jelly into the rectum so that we have a good medium for the ultrasound. And then we lubricate the surface of the condom so that the probe can go in easily. So after adequate lubrication, then the probe is gently inserted. After that, we come to the ultrasound. Care should be taken not to have any acoustic shadowing. That would mean that there is an air bubble between the condom and the transducer. You can adjust the height of the machine. और बाहर ना rotate. Yes. Yeah, so you have to adjust it to your convenience, and then That's the bladder, and that's the prostate. You can see how well the capsule is delineated here. You can adjust the gain. It should not be too bright or it should not be too dark. And then once we have adjusted everything, we just scroll. We go across the prostate from left to right, and we try to understand the anatomy. So initially can be done in 50 mm depth, and once you screen the entire prostate, you can save the image, and then again come back to the center and identify the urethra, and then mark it as line. Then you take it all the way to the right and mark it as right. You can go to the left corner of the prostate until you stop seeing it as left. So now this gives a very good idea for the surgeon to know exactly where he is working. And then after that we reduce the depth to 30 mm, which is ideal for screening the prostate for any suspicious lesion. So we'll adjust the gain a little bit, and then we scroll again from left to right. Now I've stopped seeing the prostate, and then slowly I start coming from the left to the right. And that's it. You save it. Again we go back to the left from the right, so that we have an idea and we can review the images later on. Now, to measure the prostate, we need to be in 50 or 60 mm depth, and then again we identify the urethra. That's the urethra, and that's the corresponding angle which is being shown, and we press dual transfers, and then we can see that we are in the middle of the prostate, and then we just take a sweep from one side to the other. It will give you an axial image of the prostate. Then you can start measuring it from base to apex on the sagittal, and height and width on the axial. So here we can see the length, that's the height, and that's the width. And then we have the volume, PSA density along with the measurements. Now we save this frame so that it is there for reference. So once we have done that, now we will come to screening the prostate. We will usually prefer to do it on 30 mm depth. We are starting from the right. We are starting from the right, and you can see there is good ductal pattern here. You can see the small ducts. There is no loss of ductal pattern or any abnormal echoic smudgy area. That's the transitional zone coming into picture. We are moving towards the midline. You can see the urethra here, and also the ejaculatory duct. So the disease is mainly on the left side. You can see loss of ductal pattern with capsular bulge, and these are all hyperechoic foci which will be there inside the tumor, as that should be a Primus 5 lesion. And as we go to the peripheral zone on the left, you can see the mid and apex of the prostate appears hyperechoic and smudgy in appearance. We also see a cyst, which is hyperechoic. It means there is a cyst there, and also some internal hyperechoic septate on the extreme lateral of the prostate on the left side. So this would be categorized as Primus 5. Smudgy appearance with capsular bulge and hyperechoic foci. All these are characteristic features of the Primus 5 lesion. So once we have done the screening, we know where the lesion is, and then we can start our biopsy. So we are doing a transperineal today. So we will turn on our transperineal guide, which is here, and then we get the grid. And we can start right away from the left lateral. It is a well-rounded lesion. So we'll take it from the lateral most ones. So once the probe is installed, we check the probe whether it's firing well or not. So once we check it, we can start doing the biopsy. And now we go to the extreme left of the prostate, and then we take the biopsy. So ideally we want to angle it a bit so that we'll get a good probe. This is the left extreme lateral view. Okay. And then we come to the lateral part of the prostate, which has a hypoechoic area and also the corresponding angle, which can be correlated on the left corner of the screen. Yeah. Here we take so that's the median, left lateral. And also take it from the posterior left lateral. Now we are coming to the urethra. So that is the midline, and we are taking medial just beside it. Left medial mid-apex. Left medial mid-base. We've covered the medial aspect of the prostate in two parts, that is mid-apex and mid-base. And then as we come, we'll take a target from the suspicious area here. left anterior targeted. Now coming to the right side, you can do it in continuity. So you can start from the medial aspect first. That's the middle. Right medial mid apex. And then you cover the next half of the prostate. Right medial mid base. Right medial mid base. And finally we come to the right lateral most part of the prostate. Let's take one pore here, because lengthwise it's not much. So we should be able to cover it in a single pore. Come back, review again where all we have taken the course. Because of the high resolution of the ultrasound, we will be exactly we'll be able to delineate exactly where we have taken the biopsies from. So we can see the tracks here, you can see the tracks here, also here. That's the tract on the lateral plus. I think we have adequately covered it. That should go. After reviewing, and if you're satisfied, then you can just end the biopsy. And we also infiltrate the wound with local anesthesia so that the patient is pain-free in the post-op period. Screening camera. Just give compression for a minute, and then we can tell our anesthesia counterparts to take over.